HIV testing and diagnosis. Learning objectives. Characteristics of the HIV tests used in Pakistan and approved by World Health Organization. Rationale of HIV screening, confirmatory and molecular tests. Guiding principles of HIV testing, including 5 Cs, which includes consent, confidentiality, counseling, correct test results, and connection to the care and support services. World Health Organization recommend HIV diagnosis by 3-test strategy on rapid testing kits. These are also known as point-of-care tests. Screening and confirmatory tests such as sensitivity and specificity of WHO recommended HIV testing kits. We will also talk about voluntary HIV confidential counseling and testing, care provider initiated HIV testing and counseling, community-based HIV testing and counseling, and self-testing. Merits and demerits of different approaches. Nucleic acid tests or NAC tests and viral load by PCR tests for diagnosis and monitoring of CD4 count, direct test, indirect test, reference ranges for monitoring, etc. HIV testing is based on either the identification of HIV antigen or HIV antibody tests. HIV antigen tests in which we detect the protein P24, GP41 and GP120 which are present on HIV virus, and they can be detected in blood and in body fluids few days after HIV infection. These tests may become negative during treatment. As it detects all the viral antigens, it is a direct test, and these tests are not performed routinely. HIV antibody tests, on the other hand, are the body's response to HIV infection, and it is followed by the production of IgM, IgG, and IgA antibodies against various antigens of HIV, and these are used as the surrogate markers of HIV infection. These tests remain positive for a long time, even after viral suppression. These tests are based on the response of the body to infection, and it provides indirect evidence of infection, and these tests are commonly performed for HIV diagnosis. Based on its utilization, we classify the tests into screening tests as well as confirmatory tests. Screening tests are highly sensitive and can detect the infection at its earliest stage. They are economical and may be adapted for large populations. ELISA and CLIA are used as in well-equipped laboratories and blood transfusion services. But in WHO 3-test strategy, we use Abbott Determine HIV-1-2 antigen and antibody compo test. This is used as the first test or screening test which detects P24 antigen as well as antibodies to HIV-1 and 2. Confirmatory tests that are recommended. The second test which WHO strategy recommends is Uni-Gold recombinant HIV-1 and 2. Then the third test is the SD Bioline HIV-1-2 3.0 for the differential and qualitative detection of all isotypes of antibodies including IgG, IgM and IgA, which are specific to HIV-1 and also include the subtype O and HIV-2 simultaneously. So this is known as wide spectrum confirmatory tests. 2 tests are performed for confirmation of diagnosis. WHO strategy recommend that these 3 tests should be performed, and the first 2 tests should come positive, and the third test will also come positive. Western blot is sometimes used in some of the countries, but it is not recommended in the testing strategy of WHO. Nucleic acid tests and PCR are virological molecular tests, also known as NET tests, and it detects active viral infection. There are 2 common formats in clinical practice. One is qualitative PCR performed by GeneXpert HIV-1 qual assay, which detects presence or absence of HIV viral RNA. And another test is the quantitative PCR test, which detects viral load, and it is used to monitor the patient on ART. These tests are also used for early infant diagnosis. There are certain situations in which, although the person is infected with HIV, the test appears negative, and these are known as false negative tests. One period is known as eclipse period. This is a period between HIV infection and the detection of virological markers such as HIV RNA, DNA, or P24 antigen, which is a direct test. And generally, this period ranges from a few days to a couple of weeks. Then there is another situation which is known as window period, which refers to the time between HIV exposure and when a test can detect HIV antibodies in the body. Antibody tests can usually detect HIV infection 21 to 90 days after the exposure. Most of the rapid tests are antibody tests. Therefore, HIV antibody tests may fail to detect HIV infection if done immediately after exposure. HIV tests are done for various purposes, one of which is HIV surveillance. Second one is screening of blood and blood products. And third one is HIV diagnosis. When a person is infected with HIV, there are certain dynamics that are appearing in the body. The day on which the HIV virus enters the body is depicted as a 0 day, and from then onwards, we look at the dynamics of the various markers which become detectable in the body of person who is infected. The time of infection from entry of the virus to the detection of the viral markers like RNA, they take about 3 to 7 days to appear. So the earliest time when an HIV infection can be detected in the body are sometimes 3 days after the infection, and sometimes it may take as long as 7 days. Then there is detection of the P24 antigen that becomes detectable generally 8 to 9 days after the infection. IgM antibodies against GP41 are detectable almost 3 weeks after infection, and anti-P24 IgG after almost 4 weeks after infection, while anti-GP120 antibodies after almost 38 days of infection. Interpretation of the tests according to the WHO criteria for adults and adolescents. If a screening test is done properly at the appropriate time, that is after 3 or 4 weeks of infection, and the result is negative, no further testing is required, and the negative report is issued to the client. If it is done during the window period, that is the first 3 weeks, then it has to be repeated after 2 to 3 weeks, and based on the risk behavior, a follow-up screening frequency has to be determined. For a positive screening test, the result has to be confirmed by 2 confirmatory tests based on WHO criteria. If all the 3 tests are positive, the subject is confirmed HIV positive. But if the results are discordant, all the 3 tests are to be repeated with a fresh sample. Interpretation of the tests in infants and children is a challenging one. Rapid diagnostic tests should not be used to test HIV exposure in infants less than 4 months of age. For infants between the 4 to 18 months, HIV exposure is tested by using rapid diagnostic tests in the mother. When testing mother is not possible, it is important to not consider a negative rapid diagnostic test from an HIV-exposed infant between 4 and 18 months as a definitive test for exposure. HIV infection in this age group can only be definitively confirmed by using virological tests. HIV RNA PCR is recommended for all children under 18 months of the age, while an HIV ART treatment should be started regardless of the mode of transmission. Early infant diagnosis refers to the testing of infants to determine their HIV status. Given that the HIV can be acquired in utero either before, during, or after delivery, or by breastfeeding, or via parental exposure. Purpose of early infant diagnosis is to detect HIV exposure in infants as early as possible to prevent morbidity and mortality. EID can no longer be considered primarily a one-test process. It requires additional testing over the duration of exposure, for example, 6 weeks, 4 months, and 9 months after interruption of the treatment. This includes ensuring that ART initiation is not delayed in those infants found to have HIV infection. WHO recommends the following tests for early infant diagnosis, including virological test or NET test validated for EID, which includes qualitative point of care test, which is again a combo test. Then there is a Cepheid gene expert HIV-1 qualitative test and quantitative HIV DNA or HIV RNA PCR. For HIV testing in infants and children, please consider the table 2, the HIV testing in infants and children, which is appended with this book. Timings of nucleic acid tests in infants, it is recommended as follows. At birth, only if HIV risk of transmission is high and it identifies babies infected in utero. At 6 weeks for all HIV exposed infants, as it identifies babies infected before, during, or immediately after delivery. The timing to repeat in a test should be considered if breastfeeding practices are there and there is a risk of HIV infection from mother which continues during breastfeeding. So that the timings that are recommended includes at 4 months of the symptomatic, even if previously test is negative, at 9 months, even if asymptomatic and previous tests are negative, at 18 months or 4 to 6 weeks after the cessation of breastfeeding. All symptomatic infants and children less than 18 months should be tested with a NET test, and all the symptomatic children above 18 months with rapid diagnostic tests. A second confirmatory test must follow a positive initial test. For HIV testing, please remember the 5 C's, which includes consent, confidentiality, counseling, correct test results, and connections of positive cases with the proper HIV care facility. HIV testing is recommended in various situations. The most common one is provider-initiated testing and counseling. All the key populations and their partners in Pakistan should be offered provider-initiated testing and counseling. In addition, HIV testing and counseling should be considered in adults, adolescents, or children who present with signs and symptoms or medical conditions that could indicate an HIV infection, or who have exposed to risk factors for HIV transmission, like a positive spouse or positive mother, or where there is a history of blood transfusion, injections, and unsafe sex. HIV testing and counseling should also be considered in patients presenting with sexually transmitted infections, disseminated tuberculosis, or for antenatal care in geographically prioritized areas with high burden of non-HIV or high prevalence of transmission risks of HIV. In Pakistan, provider-initiated testing and counseling is the most common route for referral to the testing center. Testing is also recommended in another situation such as community-based HIV testing and counseling, self-testing, or retesting to verify an HIV positive result. Retesting prior to enrollment in care is only recommended in situation when the testing is done at some other center and there is a possibility that the diagnosis may not be correct. But if the testing is done at this facility, then of course we cannot delay the ART therapy as the results are done over here and proper WHO protocol has been followed. Retesting of previously HIV negative people is required to verify an HIV negative status if there are situations in which the person is exposed to the virus. HIV retesting is needed only for HIV negative individuals who report recent or ongoing risk of exposure. Retesting is also required if the initial tests was done during window period, or if the person is at high risk, it should be done at least annually. Provider-initiated testing and counseling for children is offered to all children who are malnourished, have recurrent serious infections like pneumonia, meningitis, or bacteremias, or have a severe or atypical presentations suggestive of an advanced HIV infection. Similarly, provider-initiated testing and counseling is also required in pregnancy. This table present you the situation in an antenatal clinic as well as when a mother is attending the postnatal clinics. Over here, there are different situations, particularly during first and second trimester of pregnancy. If the testing was done, again, the test has to be done during third trimester of pregnancy. And then there are various situations in which the testing is recommended, sometimes 6 weeks after delivery. And if the mother is positive or breastfeeding, then the test has to be repeated at various periods of time, as mentioned in the table. Steps involved in the testing and counseling are as number one, recommend HIV testing whenever there are suspicions. Second step is to provide brief pre-test information and education about HIV/AIDS after ensuring the confidentiality and obtaining the informed consent. The third step is to obtain a specimen for HIV testing. Fourth one is to perform rapid tests according to WHO strategy. And for a negative test, the result is issued with the post-test counseling to prevent HIV acquisition in future. And if the test is positive, then the confirmatory tests done, and after 3-test strategy, deliver the HIV results after due post-test counseling, and then refer the patient to the antiretroviral therapy center. Your 3-test strategy is so important that although we have covered it in our previous slides, we'd like to repeat it once again, that the initial screening is done by determining HIV-1/2 antigen antibody combo tests, because it detects both HIV antigen as well as antibodies, and this is the earliest test which can detect, the rapid test which can detect the infection. Another is the Unigold recombinant HIV-1 and 2 tests, which is used as a confirmatory tests. And third one is SD Bioline HIV-1/2 3.0, which can differentiate qualitative detection of all isotypes, IgG, IgM, and Ig antibodies specific to HIV-1, and it also includes subtypes O and HIV-2 simultaneously. According to the WHO's algorithm, HIV-1/2 Abbott determined combo test is the first test which is done to screen the cases on the basis of suspicion of HIV infection or due to all other factors for which the client is referred for HIV testing. This is a combo test which is FDA approved and a rapid part of care test. It detects both HIV-1 and HIV-2 antibodies, as well as it detects free HIV-1 P24 antigen. This antigen antibody test is also known as fourth generation test, and it has the ability to identify HIV earlier than antibody only tests, like second and third generation of the test. It enables healthcare providers to suspect or an early diagnosis of HIV infection, but that has to be confirmed by 2 additional tests. We'll also show you the video of each test separately. However, to summarize it, remove the protective foil cover from each test unit and lay the test unit flat on the workstation. The test should be initiated within 2 hours after removing the protective foil cover from each test unit. This combo test must only be used with capillary blood or venous blood, serum or EDTA plasma. So apply 350 ml of sample with a precision pipette and read the test results between 20 and 30 minutes after adding 1 drop of chase buffer. Now, how to perform the finger prick? Clean the finger of the person being tested with an antiseptic wipe. Allow the finger to dry thoroughly, or you can wipe it with a dry sterile gauze. Using a sterile lancet capable of producing 50 microliter of blood, puncture the side of the skin just in the center of the finger pad and wipe away the first drop with a sterile gauze. Quickly express the blood down the fingertip by gently milking across the entire finger length to the last joint, but not to the end of the fingertip. Collect the second drop of the blood by holding the capillary tube horizontally and touch the tip of the capillary tube to the blood drop that has been generated. Please note that the filling of the capillary is automatic and you do not need to squeeze the bulb while the sample is being collected in the capillary. I mentioned earlier that this determined combo test detects both antibodies as well as antigen. So a positive reactive sample of the antibody is shown on the left side of the pad and antigen reactivity is shown on the right side of the pad. Now we will talk about how to interpret the result. So if there are two lines in the antigen reactive area or site, it means that the antigen is present. If there are two lines on both the reaction sites, that's antigen antibody, it means that both antigen and antibody both are present. And if there are two lines in the antibody reactive area, it means that the test is reactive positive for the presence of antibodies only. If only test line is coming positive, that is a single line on both the sides of the cassettes, it means that the test is valid and it is a negative test. However, the test will become invalid if the control line is not seen on any of the sites, and if the test is negative, that report can be issued immediately. But if the test is showing any of the positive findings like antigen or antibody, then the test will be done repeated, and the next test will be done with the second and third tests using Unigod recombinant HIV 1 and 2 and SD bioline tests. Second test of WHO strategy is Unigod recombinant HIV 1-2 test. This test has to be done if the first test, that is the combo test, is positive and the finger prick and the procedure for collection of the sample remains the same. Unigod recombinant test, the collection procedures, the Diagnostic procedures remain the same. However, the dropper bottle of the wash solution is kept in a vertical position and 4 drops of the wash solutions are placed on the sample part. The timer is set for 10 minutes and the results must be read between 10 and 12 minutes but not later than that. Board, the test procedure: perform no more than 10 tests at one time. Draw up adequate sample to the first graduation marked on the pipette using one of the disposable pipettes included in the kit. Hold the pipette vertically over the sample port and add one free falling drop of the sample. Add 4 drops of washed solution to the sample port. Set the timer for 10 minutes and start timing the test. Of this test is also similar to the one we discussed about, that there is a presence of test control line is a must. And if the test line is positive, it will be reported as positive, and if it's not positive, the test line is negative, but the control line must be present, then the test will be reported as non-reactive. Result will be reported as invalid if the line of control is not visible or is not appropriate. So that test will become invalid and that has to be repeated. SD BioLine HIV 123.0 is the third test in WHO strategy. And this test is an immunochromatographic assay for the differential and qualitative detection of all isotypes, that is IgG, IgM, and IgA antibodies specific to HIV-1, including subtypes O and HIV-2 simultaneously in the human serum, plasma, or the whole blood. This is a highly sensitive test even to IgM during early infectious stage. It also differentiates the test result between HIV type 1 and HIV-2 by clear band formation. It is the third generation method and it's considered highly sensitive, almost 100% sensitive, and its specificity is 99.8%. Test, which is the third test in the WHO protocol, dispense the blood 20 microliter onto the specimen well labeled as S and wait for 10 to 20 minutes. At the completion of the 20 minutes, the results are read. If there is only one single line at C, which is a control line, the test is negative. If there are 2 lines with one at C and second line at 2, it is HIV-2 positive. If there are 2 lines with one at C and second one at number 1, it is HIV-1 positive. If there is no line at C, lines at 1 and 2 are invalid. If test 1 and test 2 both are positive, that has to be finally confirmed with the third test, and the test procedure remains the same, similar. And if this test is also positive, this person is diagnosed as HIV positive and is connected with the ART center for the follow-up. We have already discussed the HIV testing protocol of World Health Organization, and these testing algorithms has improved the quality of reporting and reduced the chances of misclassification. The figure on the next slide shows the national HIV testing algorithm for adults and children 18 months of age and above. This slide summarizes what we have talked about, that is the algorithm of HIV testing using 3-test strategy of World Health Organization. This is just to be printed on the side so that everybody can follow the same procedure. This serial rapid test algorithm should be printed and displayed in the working area so that everybody follows it accordingly. Testing is one of the most important tests offered in the clinical practice, and the quality assurance is the responsibility of the manager. The quality assurance at HIV testing services is implemented through quality management systems comprising of internal quality control and external quality assessment. All the proper precautions that are to be required must be implemented, and every time the manager has to keep on not only monitoring the quality control but also keep reporting it and documenting it for review and audit. We have also discussed the other lab tests that are required, and as soon as after the confirmation of HIV positive, patient is referred for the ART. These tests are done at referral lab, and the patient is provided instructions and referral form is completed at ART center. All the reports are to be collected and kept on the file at ART center, and it is the responsibility of the technicians working at the ART to collect the reports and put it in the file properly. Baseline CD4 cell counts are still recommended but are not mandatory to initiate antiretroviral therapy. However, the CD4 counts are done during the process to ascertain the immune status and repeated as per the guidelines and the advice of the treating physician. There are other tests for sexually transmitted infections, hepatitis B surface antigen, anti-HCV antibodies, and pregnancy tests for women infertile age should also be done. It's also advisable to collect the samples for baseline investigations and send it to the referral lab to prevent delays and loss of follow-up of positive cases. These tests include complete blood counts, liver function tests, urea, creatinine, urine routine examination, hepatitis B, A1C, to ascertain the status of glucose tolerance, sputum for gene expert, or any other tests requested by the ART physician. CD4 count are offered through this PIMA point of care CD4 analyzer, and it's a point of care test, and again the test is done on the cassettes. However, the capillary blood or venous sample can be used, and there are little bit differences in the procedures. Are also provided at ARDs. The PIMA part of care CD4 analyzer is used. This analyzer is used for the measurement of venous CD4 count. Measurement of capillary CD4 count has also been included in the SOPs provided in the unlikely event that a patient refuses venous sampling but agrees to a finger prick test. For count is done by the PIMA part of care CD4 analyzer. This is available at most of the ART centers, and the instructions for the use of the test and the equipment are provided, along with a direct training by the vendors is available, and all the instructions that are given should be followed accordingly. Before count is done as per the procedures outlined, and use the same plan that has been given through the manual which is present, as well as the online training that is being provided, and the person who is doing it should watch the video carefully before starting the test. So the various types of sample collections are given over here, and everyone who is using it should be thoroughly competent and keep it stepwise before starting the test. Management of stock of the diagnostic as well as therapeutic services are very, very important at each and every ART. Every facility providing these services have the staff members trained in integrated stock management. All commodities upon receipt should be counted and cross-checked with the delivery documents. They should be stored in well-lit and ventilated rooms. And the policy should be to allow first expiry, first out. Inform concerned office in writing 3 months in advance of the expiry date. Every HIV treatment service entry part should maintain stock cards for each test kit, ensure adequate stocks, and order in accordance with the NSCP and PSCP supply chain system. No commodity should expire in the stock, and to ensure it use or redistribute before expiry date. For proper storage of test kits, follow the manufacturer's instructions. I chose the HIV exposed infants risk assessment algorithm, and it should also be placed prominently in the facility, and everybody should follow it accordingly. It's a simplified algorithm for early infant diagnosis, again following the World Health Organization's protocol. Method load testing after the initiation of antiretroviral therapy. To assess the response of the ART therapy, viral load should be conducted 3 months after the ART start. An additional viral load should be checked after 3 months, that is the 6 months after the ART initiation. In certain instances, there may be a need for additional viral load testing, such as viral load should be checked at the time of the establishment of pregnancy in patients who have become pregnant while on ART, and again at 36 weeks of gestation. CD4 counts should be checked with the viral load till the patient is documented stable on ART. The table on the next page summarizes the routine testing required in patients with ART. This table shows the routine testing for persons living with HIV in relation to antiretroviral therapy. So, all the patients require baseline testing and HIV serology, hepatitis B surface antigen, hepatitis B surface antibody tests, HCV antibody, RPR, random blood sugar, X-ray test, smallpox test, particularly in children, CBC, blood and urea creatinine, ALT, urine lipstick test, and CD4 counts. HIV infection cannot be diagnosed by any single test. The best strategy is to use 3 tests as recommended by WHO. HIV services should be offered to people with signs and symptoms of HIV infection, sexually transmitted infections, tuberculosis patients, and antenatal clinic attendees, partners of people with HIV, families of index cases, key populations like persons who are taking the intravenous drugs, MSMs, transgender people, sex workers, and those with exposure to blood or blood products or blood transfusions like thalassemia or hemophiliac patients, parenteral injections and infusions, pregnant women, infants, and children of HIV positive mothers, children with signs and symptoms of HIV infection, or those who have a family member living with HIV. Determine combo test detects both antigen as well as antibodies HIV-1 and HIV-2. Uni-Gold recombinant HIV-1 and 2 test is a rapid immunoassay for the qualitative detection of antibodies to HIV-1 and or HIV-2. BioLine HIV 3.0 test is the third test, and all the three tests must be positive to diagnose HIV positive case. As soon as after the confirmation of HIV positive patient is required to put on ART. On their first visit or those returning to care, patients should be assessed for ongoing co-infections and opportunistic infections before a rapid ART initiation is offered, and that should include pulmonary and extrapulmonary tuberculosis and cryptococcal disease. Retesting people on ART is not recommended. There are potential risks of incorrect diagnosis. Thank you very much for your active participation and patient listening and your contribution and feedback to improve our presentation. Thanks again.